realize.
So good evening, everyone. So welcome to our next episode of DOS-PEP and Strabismus and Neuro module. And today we are very lucky, and it gives me immense pleasure to announce our speakers for today, Professor Pradeep Sharma, sir. And sir, we all know an internationally recognized strabismus surgeon, as well as probably one of the best teacher I have ever come across. He has trained generation of squid surgeon from RP Center, and he has written a very important book, which I think almost all of us have gone through, Strabismus Simplified. And beyond all this teaching, surgeon, sir is a very excellent poet by heart and a very wonderful human being. So with this, I would like to invite sir to our DOS PEP program, and I request our coordinator, Dr. Pranita Sahai, to introduce sir and invite our other guest and continue with the lecture. Pranita?
Yeah, thank you, sir. So, welcome everyone to the DOS-PEP Module 3 of Strabismus and Neuro-Ophthalmology. And today we are on the 15th lecture of Strabismus. And we have an eminent speaker, Professor Pradeep Sharma, sir, who requires no introduction. We know him all. And he's going to talk about a complex topic that is nystagmus. And he's going to present it. I know his classes are just wonderful, I'm sure. He is going to make this complex topic very simple and for all the postgraduate students to understand. Dr. Abhipsa Sharma and Dr. Anita Ganger, who are our Strabismus module coordinators, will be joining us in this module for discussions. Professor Pradeep Sharma, sir, he's an ex-professor from AIIMS, Delhi, and is currently the Director of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at Center for Sight, Center for Sight Eye Hospital chains in India. He's done a fellowship for advanced training in strabismus from the prestigious Jules Steen, UCLA, Wills Eye Hospital, Philadelphia, and Richmond, and various other hospitals in US. He has also been awarded by the International Strabismological Association in 2001 for his work in the field of strabismus. He is a visiting faculty in Orbis and the Flying Eye Hospital in the year 2002. He is the first Asian who was invited to deliver the Knapp Memorial Lecture by the AAPOS in Vancouver. He has received achievement awards by AAO in 2017. He is also the awardee of AIO's Rangachari Award, the Athawale, and several state oration awards. And the Dr. Baldev Singh Oration Award. And he has over 225 scientific articles published in index journals, which is just something amazing to have in the field of strabismus and in the field of publications. He's published a very important book, which I think every postgraduate has read, that sir has just highlighted, that is Strabismus Simplified Essentials of Ophthalmology. He's been the past president and founder member of the Pediatric Ophthalmology Society of India. And he also has a passion of music, and he has his own website and YouTube channel, that is the Strabis Music, which the link sir has shared here, and you can look into it if you are interested. And with that, I would like to hand over the dais for the further lecture on the topic of nystagmus from sir.
Thank you, Pranita.
So we welcome you here at DOS-PEP.
Yeah, it's my pleasure to join this grand portal that you have now made it possible for these PGs to learn more and have a coordinated thing. I really thank Praful for starting this new venture in coordination with Dr. Anupam Sachdeva. And it's a pleasure to have Pranita, Anita, and Abhipsa, our old friends from RPC. So I would be talking about nystagmus, as I think have been asked to. So nystagmus, we need to understand and manage it properly. How do we do that? You must have seen children who are having eye movements which are rhythmic, regular movements which are happening. You must have seen such thing. It's a constant alternation of a slow drift sometimes or both ways. So we'll talk about these type of movement, what is there and why they happen. We all know that we have different types of eye movements. The fast refixation movement. Suppose I ask you to look from right to left, there is a fast saccade or saccades. There are smooth pursuit eye movements that we use when we are tracking slowly at a moving object. Like when you are traveling, you're looking outside, then you will be slowly tracking that, and then sometimes there will be a quick correction movement of a fast, that is opticokinetic nystagmus. Then we have the vergence or the convergence movements, that means when we are looking far and then near, and vestibular. But the most important thing which we usually take it for granted is the fixation. That means when we are looking at an object, can we keep the eye steady? Now, this is something which we take it for granted. Here comes the problem: when something goes wrong, it creates a nystagmus. There are three main control mechanisms for maintaining the steady gaze. One is the fixation or the position maintenance system. Now, in this, you should understand that there are smooth glycades and microsaccades which are happening at a very small level, which is repositioning the eye fovea again and again. Now, it is important that we cannot constantly look from the same point, because the cones would get after bleach first after a few seconds. So we need to have a recorrection all the time. So these position maintenance system maintains the clarity of vision all through. There is a second one: whenever we move our head, then we have to continue the fixation, and that is a vestibular ocular reflex which controls that. And the third is the gaze holding. So when we look to an other side, we need to maintain the gaze at that eccentric position. Here the neural integrator comes in, which maintains the position which is now achieved. And if there is something wrong with the neural integrator, again there will be a problem where that will be a sliding back of the gaze. So nystagmus can happen. So broadly speaking, there can be problems in which in these three situations that the movements can go wrong, and nystagmus and the nystagmoid movements are the result that happens. If there is a slow drift, it's a nystagmus. If there are saccadic intrusions which happen in these, then we call it the nystagmoid movements. Let's go into a little more detail. If you have gone through the books, you might see a classification of nystagmus. One is physiologic. So that means like optokinetic nystagmus. All of us may have experienced the railroad nystagmus. When we're traveling out and looking at a fellow's eye, we might see that the eyes are constantly moving when he is looking outside. There is a slow and fast movement which is happening. Another thing which you may have encountered is when you are taking a merry-go-round and suddenly you stop, then the eyes move in an opposite direction, the after nystagmus, which happens because of a constant movement of the vestibular system. Or you may have a comatose patient sometimes, in which if you irrigate the eardrum with 7 degrees plus temperature, then there will be a movement of the eyes. So these are physiologic nystagmus. But on the other hand, there can be pathologic nystagmus, in which we will have three types. The sensory, that means if there is some poor ocular vision cause, maybe in the retina or the optic nerve or the media opacities, which can affect the movement system, and it will result in a pathologic nystagmus of the sensory kind. The idiopathic, or ones which are having no sensory problems and no neurologic disorder, is sometimes going to be there. And then there is a condition of neurologic disorders which can cause nystagmus, which we'll talk about in a slide next. And then we mostly in childhood, what kind of nystagmus we encounter, we will try to focus in this talk. Now, physiologic nystagmus, as I mentioned, the optokinetic nystagmus or the railroad nystagmus, the vestibular, caloric or positional, the endpoint nystagmus. When we look on the side, then also there may be some nystagmus, which is an endpoint nystagmus. Again, it is physiologic. And then there is a voluntary nystagmus, which some exceptional people can create a nystagmus by volition. The nystagmoid movements that we usually see are the Heman-Bilchowski's phenomenon. That means a person having a poor vision has the drifting of the eyes, and then it has a up and down movement, or the convergence retraction nystagmus. Sometimes we have a very chaotic eye movements, the opsoclonus or the ocular bobbings. So these are the nystagmoid movements. When we come back to nystagmus again, as we said, it is a regular rhythmic to and fro eye movement. So the important thing to remember is a nystagmus has to have a regular rhythm. So some occasional movements are not going to be classified as nystagmus. Nystagmus has to have a smooth movement on one side, and then there is a fast movement, or there may be a sinusoidal movement, but they are regular rhythmic movement which keep on going in a loop fashion. They may be, as I just mentioned, sensory. They may be an infantile nystagmus syndrome, the motor nystagmus. They may be the spasmus nutans, which may be benign or the malignant variety, and there may be a fusional maldevelopment nystagmus, and we'll talk about this into little more detail as we go on. The acquired nystagmus, which may be because of some underlying neurologic lesions, also we'll just mention. We won't go into details because that would be more of neurology that we'll be discussing. So these may be in the form of downbeat nystagmus. Now, what do we mean by downbeat? Downbeat means the fast component is downwards. So there is a slow recovery on the upwards, and then there's a fast component down. That's called a downbeat. This is because of cervicomedullary junction problems or something there in the medial longitudinal fasciculus or the cerebellopontine angle tumors. Upbeat nystagmus may be because of anterior vermis, cerebellum, medulla lesions. Torsional nystagmus, any brainstem lesions can give rise to a torsional nystagmus, and you may have a diencephalon, cellar, paracellar lesions which cause a seesaw nystagmus. That means right eye goes up, left eye goes down, and then the left eye goes up, right eye goes down. Periodic alternating nystagmus is a special type in which you have a regular alternation periodically. That means the right beating for some time, then there is a still, and then there's a left beating after some time. These may be because of posterior fossa lesion, brainstem, or cerebellum. There is one specific variety, the Bruns nystagmus, which has a slow and fast component combination. This is because of the CPA angle tumor or acoustic neurinomas. And then we have the central vestibular nystagmus, the convergence retraction nystagmus like dorsal midbrain syndrome, as in pinealoma, dissociated nystagmus as the MLF and internuclear ophthalmoplegia. The one important thing that you need to remember is any acquired asymmetric nystagmus which is there and which is having oscillopsia, there we would have to do always an imaging. Like this child who had a nystagmus. Now this type of nystagmus, you see there is a dissociation. The right and the left eye are moving differently. So whenever you have an asymmetric nystagmus in a child or adult, and he is complaining of oscillopsia, or he has a vertical component downbeat or upbeat, then you should always do an imaging to rule out neurological problems, and that would be life-saving. Otherwise, the nystagmus in childhood is going to be what we'll discuss right now. It may be a sensory nystagmus in which importantly you have to do a good eye examination, look into the fundus, and sometimes you may have to do an electroretinography to see the retinal pathology. The another variety that we talked about was the infantile nystagmus syndrome or the manifest nystagmus. The third is the fusional maldevelopment nystagmus, nystagmus blockage syndromes, and then these terms we'll talk about more and more, but just to repeat so that you get a hang of it. The spasmus nutans, seesaw nystagmus, vertical nystagmus, acquired asymmetric nystagmus. The ones which are in red are always going to require imaging. So keep this in mind because this could be life-saving. Now, what is sensory nystagmus? These are to and fro movements, right to left, as you can see in this video. And if you do a recording of these, you'll find they are sinusoidal movements which are tracked. They may be slow or fast, but they are having an equal movement on either side. And usually they have some problem in the vision, which is behind, and we need to look for. So any condition which is affecting the vision by the optic nerve, retinal, or congenital cataract, any cataract which is there in early childhood can give rise to a sensory nystagmus develop if you are not treated in time. So all these pathologies you have to keep in mind, and they could be leading to a sensory nystagmus. So an eye examination, a proper fundus examination, electroretinography, and VER are the things which would suggest for this kind of category of nystagmus. The other variety, which is much more commoner, is the one which may have normal visual apparatus, but they have a movements which are there. Now, this is the idiopathic infantile nystagmus, and mostly the idiopathic word may not be used, and they are seen in infancy, the first 6 months. That's why it's better not to call congenital, but an infantile nystagmus syndrome. It's also called sometimes manifest nystagmus. Typically, it is bilateral. Now see these eye movements of this child. They are initially, when he's in the first few months, you'll find they are having a right to left movements. This is also known as a triangular phase. And then the second phase comes in which there will be a little slowing of the movement, but then there is a slow and a fast component. So typically these are bilateral. Conjugate means both right and left are having the eye movement disorder of the similar kind. uh, Uniplanar, that means they are mostly horizontal. They worsen on fixation attempt and they improve when you try to converge. Some of them may have a null point. What do we mean by null point? That means there is a position in which the nystagmus becomes less, or it may sometimes become abolished. Usually, oscillopsia, or the feeling of the world moving around, which you may have encountered when you have taken a merry-go-round and suddenly stopped, you see or you feel that oscillopsia. So this is usually not complained by children in infantile nystagmus syndrome. And two-thirds of these cases may show an inverted optokinetic nystagmus response. That means when you do an OKN testing in these children, they would produce a reverse movement of OKN. Now, infantile nystagmus syndrome, as I mentioned, may have a null. And if there is a eccentric null position, that means other than the central primary position, then they would be having an abnormal head posture to take advantage of this null position. So you'll find a child walking in with a face turn like this child is having a right face turn, keeping the eyes in levo version. And why is it? Because there is a nystagmus. See this. So, and he's asked to read, and you can see that he's keeping constantly the eye position. That if you cover the right eye, which was in adduction, it maintains the left eye in abduction. So this is what you should always distinguish whenever you have an eccentric null, that is it an adduction null or is it a gaze null. So in this case, as you saw, he was maintaining with the left eye in abduction, so it's a gaze null. As against this another child who is having a similar face turn. Now I am covering the right eye which is in adduction, and you will find he is not comfortable. He shifts his head and brings the left eye in adduction. So here there is a adduction null in both the eyes. Whichever eye is allowed to fixate, it will be in adduction. This is typical of what we see in a manifest latent nystagmus or a fusional maldevelopment nystagmus. Now, another thing which you will notice about these manifest latent nystagmus is they may have associated strabismus. Like this girl who has an intermittent divergent squint. You put a Spillman occluder in front of the right eye. Gradually, the IDS breaks, becomes manifest, and also you'll notice that the nystagmus has also become more prominent now. So it's a manifest latent. It was initially less in amplitude and frequency, and after the breakage of the divergent squint, which was controlled, has become more manifest. So this is a manifest latent. That means there's a latent component which gets manifested when you cover the eye or break the squint. So this is typically seen associated with strabismus. And whenever you correct this strabismus, it again becomes latent. When you record the eye movements in these children, you will find that there will be usually a null in the center. That means they don't have a head posture, and the recording in the center is there. But when you ask them to look to the right, the nystagmus has become worse. Left again, the nystagmus has become worse. But you will also notice that when he's looking to the right, there is a right beating nystagmus. When he's looking to the left, there is a left beating nystagmus. Remember, I said beating is based on the fast component. A right beating nystagmus means the fast component is towards the right. So in the right gaze, it's a fast component beating to the right. So it's a right beating nystagmus. Similarly, when he looks to the left gaze, there will be a left beating nystagmus. Interestingly, when you cover the eye, it becomes worse. As you can compare the central positions after occlusion, the nystagmus is getting worse. Why? Because there is a latent component which has got manifested. And it's also important to remember that the seeing eye always has the fast component towards the same side. So this is a typical feature of a manifest latent nystagmus. Some children, as I said, may have infantile esotropia along with a nystagmus, and that is they have more nystagmus when they look in abduction, and when the eye is in adduction, the nystagmus is less. So they will prefer to keep a face turn. Like you can see the left picture, the child is keeping an esotropia and he's keeping the eyes in the adduction, whichever you ask him, right side or left side, but the eye remains in adduction. Now, these children, what we call as Sciantia syndrome, they have a infantile esotropia with nystagmus in abduction, also called IENA or a Sciantia syndrome. And in such cases, we will do MR recession with posterior fixation to fully correct the head posture and the esotropia. Now, spasmus nutans. Now, this is a very interesting type of nystagmus which you all should remember. Look at this picture video very carefully. You will find that this child is having a dissociated nystagmus. The left eye is beating much more than the right eye. So always remember this: right eye, left eye, there is a difference between the two. So it's a dissociated or an asymmetric nystagmus. Left eye is beating much more. So this is a spasmus nutans. Usually it's a triad of a head tilt, there will be a head nodding, and there will be an asymmetric nystagmus. If you find a child having a spasmus nutans in the first year of life, you need to do an imaging in all these children. Majority of these children are benign, but 15% may have harboring a cellular tumor. So when you do a recording, you'll find this. Typically, they have a high frequency asymmetric disconjugate nystagmus. If you do an imaging, they may have a chiasmal glioma. So do a CT or MRI in such cases of asymmetric nystagmus. There's an interesting article published recently in 2019 by Brodsky and Torado of a similar case which was picked up by doing an imaging. Another variety of nystagmus that we encounter in infancy is nystagmus blockage syndrome. Now, see that what happened, you saw the eyes were straight initially, but then there was a nystagmus. And now suddenly he has assumed a convergence, esotropia. The right eye is esotropic and the nystagmus has got arrested. So it's or blocked. So it's called a nystagmus blockage. So they have a nystagmus, but by the mechanism of adopting an esotropic position, they can block the nystagmus. So this is an interesting type of nystagmus. You will have an inverse relationship between the nystagmus and esotropia. What do we mean by that? That when the eyes are straight, there is a nystagmus, and when the eyes are esotropic, the nystagmus is gone. So either there is a nystagmus or an esotropia. And again, surgery will help in correcting these both the conditions, the esotropia as well as the nystagmus. So when we examine case of nystagmus, what do we notice? One, look at the head posture for distance and near both. It may be sometimes different. Look for any associated squint and also look for any associated albinism, oculocutaneous or just an ocular albinism. So it may be different grades of albinism, but since the gene of albinism and the infantile nystagmus are on this co-logous, so they may be having a very common association. So you'll find these children may have an oculocutaneous albinism and they have a nystagmus. When the vision is to be charted in cases of nystagmus, we have to be very careful. Why? Because if there is a latent component and you do the routine type of covering one eye and asking the person to read, he will have a drop in the vision because the moment you have covered the other eye, the nystagmus worsens and the vision drops. So when you are taking the vision, always do a binocular vision assessment with both the eyes open and then see. And if you find that there is a difference of more than 1 or 2 lines, then it means there may be a latent nystagmus which you should look forward to. And how do you assess vision in such cases? Instead of using an occluder, you have to use a +4 diopter lens over the other eye to check the vision of each eye separately. Or you have to have binocular charts in which you can use Polaroid filters to assess the vision of each eye individually. So important points in nystagmus examination. Let's focus on these points. One, there may be an abnormal head posture. Second, look for the type of eye movements. We saw there was a sensory nystagmus, there was a pendular to and fro movement. And we also saw there was jerk nystagmus in the other girl who had right or the left beating. So whenever you have a jerk nystagmus, note down whether it is a right beating, that means the fast component is towards the right side, or is it a left beating, the fast component is towards the left side, or it's a vertical jerk in which upbeat or a downbeat nystagmus may be there. Also look for, is it increasing in abduction gaze, like we have the IENA syndrome, we said that it's a nystagmus in abduction and better in adduction, or is it increasing on occluding either of the eyes, like we see in the manifest latent nystagmus. Visual acuity, as I mentioned, you should always check binocularly and reassess the monocular vision with a +4 diopter lens over the other eye. Any associated strabismus, any associated ocular disease like albinism, and always focus whether it's a unilateral asymmetric or disconjugate nystagmus, because that may be a sign of looking for imaging. Any acquired nystagmus, oscillopsia or vertical nystagmus may be indicating a neurological disease underlying, so you should always do an imaging in these cases. So how do you measure the face turn? You can use a simple protractor and scale to align with the visual axis, and the zero of the protractor is with the sagittal axis. The angle formed between the two will tell you the abnormal head posture. So this is the right face turn in this child which we are measuring, and you can see that. With the same mechanism, there is a chin up or chin down. You can put the protractor on the side and measure whether it's a how many degrees of chin up or chin down, or a torsional nystagmus. So you document the nystagmus on a chart in the 9 gazes, just like the pictures. Here, the nystagmus is documented with a bidirectional arrow. If it is a to and fro movement, that is a pendular nystagmus. But if there is a jerk nystagmus, it is always shown by a single ticked arrow. So there will be like the left or the right beating, as you can see in the top pictures. And the number of bars and the numbers of arrowheads indicate the frequency and the amplitude. A torsional nystagmus is indicated by a curved line. You can also do an electronystagmography. What is electronystagmography? Basically, it's a electrooculography, and the electrodes are placed both at the lateral canthi and the medial canthi with the neutral on the forehead, and the recordings are made. And when you get the recording, it's basically the eye movements which are spontaneously happening in nystagmus, which will be recorded as this. So, and in different gazes, you will see the movements are different. So you find here in the dextro version, it's a very, very chaotic, very fast nystagmus which is there. In primary position, it has got little less, but in the levo version, it's got quite corrected or less with only a few artifacts. So this indicates there is a levo version null, and there would be a abnormal head posture, right-sided face turn. So ENG will corroborate with your clinical examination of the abnormal head posture. The type of eye movements that you will record in these ENG may be of these types. That means there is a fast component and a slow component. In the mentioned as A, you'll see that the blue arrow is indicating the slow component, which is a slower movement, and there is a left beating, a fast component. By convention, we always have in electronystagmography an upward movement is right side and a downward movement is left side. So in this upper picture, you see there is a fast component towards the left, and there is a regularly moving slow component. So this is typical of a vestibular nystagmus. The second picture or graph shows a sinusoidal movement, which is a regular movement which is there, and that is a typical of pendular nystagmus. The C graph is showing you a jerk, which is a slower component, which is having a constantly increasing velocity slow phase. And this is typical of what we see in a manifest nystagmus, an accelerating nystagmus. And in the next one, you see a jerk, again a slow component, which is marked by the blue arrow, and it is gradually reducing its in velocity. So it's becoming more and more flatter. That indicates it's a slower, gradually getting slower or decelerating slow phase. This is seen in a manifest latent or a fusional maldevelopment nystagmus. Now, when you have a child who has a face turn, you should devote little more time, 3 to 5 minutes minimum, and to see if there is a constantly one-sided face turn or is it periodically alternating, changing. So if you ask him to keep on watching a video on a TV, for example, and observe his face turn, you might find that he has been shifting his face turn from side to side over a 3 to 5 minutes period. This is indicative of a periodic alternating nystagmus or PAN. Now, these are different types of nystagmus which has to be tackled surgically differently. And here, just remember, a 4 horizontal muscle supramaximal recession is done, or a bilateral augmented Anderson procedure is done for a PAN or a periodic alternating nystagmus. How do we manage these cases? Non-surgical management, optimal prescription should be given. Use of tinted glasses if there is an albinism associated. Contact lenses may be given for high myopes or high refractive errors. Usually they do not have much of dampening effect. There may be a short-term dampening effect. So contact lens per se do not really dampen nystagmus, but they do help a person having a high refractive error. Prisms base out can be given, and these are usually seen for smaller face turns that you may use. Auditory biofeedback and acupuncture have been studied and they do have some effect, but they are at the moment not practically useful clinically. Study done by us in RPC, we had shown that reduction of the congenital nystagmus amplitude with auditory biofeedback can be achieved, but this requires a constant biofeedback mechanism, which is practically not possible to give a child. Similarly, acupuncture also works, and acupuncture is an interesting Chinese thing which you have a acupuncture needle in the sternocleidomastoid. The acupuncture points or acupoints for nystagmus are supposed to be in the sternocleidomastoid muscle in the neck, and we have seen that it does damp the nystagmus, but the effect is short-lived, about 5 minutes, and then you have to keep on twirling the needle to have the maintenance of this same effect, which is again not practically possible. Medical treatment has been tried in the form of baclofen in acquired periodic alternating nystagmus, but it has not been found to be effective in congenital PAN. Gabapentin has also been used in some studies. Brinzolamide eye drops have been tried by Hertel and also in an RPC study, and they do have some effect. Whether it is a lasting effect or a placebo, we cannot really find much use for long term. How do we manage these cases surgically? Now, this is the most gratifying thing if we can treat a person having a head posture and improve his condition. Now, the strategies for surgical management are basically these five. One, shift the eccentric null position to the center so that he does not adopt the abnormal head posture to take advantage of the null. So, this is one strategy. Second is we induce artificial divergence. Mind you that we said that convergence damps the nystagmus. So, if you make him converge even for straight per distance, then he will have some dampening of the nystagmus. So you will have to induce artificial divergence. This can be used using prisms, or sometimes we can use a posterior fixation suture or a MR recession may induce the artificial divergence. Any associated strabismus, like we talked about IENA, infantile esotropia, Shantia syndromes, or we talked about intermittent divergent squints with nystagmus, you can just treat the strabismus and then the manifest component becomes latent in the manifest latent nystagmus. The other two varieties of strategies, the four horizontal muscle recessions and the Hertel-Delosso procedure, which is an interesting procedure in which tenotomizing the four horizontal recti and resuturing without any recession or resection has been claimed to be effective. This we'll talk about later. Now, how do you plan a case having a abnormal head posture? So schematically, if you see a person having a face turn to the left would have his eyes in dextroversion as shown in the upper cartoon. Now the eyes are in the dextroversion. What you need to do is shift this to the center. So you would have to do a right lateral rectus recession and the left medial rectus recession, the yoke muscle recessions, and that was what was described by Anderson from Australia, Melbourne. At the same time, almost, Kestenbaum had described a combination of both recession and the resection of the opposite muscles. So, just in the similar situation, Kestenbaum would do RLR recession, right medial rectus resections. At the same time, left medial rectus recession and left lateral rectus resection. So, the four muscle recession surgery was described by Kestenbaum. Both achieved the correction of the abnormal head posture. A Japanese worker Goto described only the resection component without recessions, and that also was found to be effective. But the most effect comes with the augmented Andersons that we'll talk about. So this surgery is usually planned at around 3 to 4 years of age before the child goes to school, so that we can make his life better and have him have good eyesight. Anderson-Kestenbaum surgery has been mentioned in the literature in several avatars or variations. The Anderson yoke muscle recession, the Goto yoke muscle resection, Kestenbaum, as I mentioned, four muscle recession, resection, all the horizontal recti, but just 5 mm was what was described by him. And then it was found to be less effective. So Parkes modified it. So classic MR recession resection 5, 6, 7, 8 formula. And then augmented Parkes was adding 40% more amount to the surgery. 60% augmentation was another triad which is done. And the modified Kestenbaum, which was mentioned by my senior Dr. Prem Prakash as 6699 modified Kestenbaum surgery. But usually we do an augmented Anderson's procedure. And what is to be noted here is yoke muscles, but the amounts are augmented. The MR recession is 9 mm recession, LR recession is 12 mm recession. See here this case who has been operated similarly, and his head posture, left gaze, left sided head posture has been straightened by after the surgery. So this we had published in JPOS in 2006. And here there is a here the interesting thing is that the surgery is not much different. It's only because of the large amounts that it's more difficult to do. So one should be able to do it with the fornix incision. And here the same lateral rectus is being hooked and 60 vicryl sutures are passed. And after the 3-point suturing, the muscle is disinserted. The intermuscular septum has already been separated. And then we mark it. And because we have to mark 12 mm, we will mark it 6 plus 6 in two halves so that we have a 12 mm measurement. Remember, the arc measurement versus chord measurement is going to be discrepancy. So always do it in two goes or use a curved ruler. And then you pass these sutures at 12 mm for the lateral rectus. And for the medial rectus, it will be 9 mm. So once this is done, and you can hope to get it corrected, and the ENG also would improve from pre-op, as you can see here, and the post-op showing almost the neutralization or dulling of the movements which are seen on the left-hand side picture. Some children may have a PAN, and we talked about this earlier, a periodic alternating nystagmus. That means their head posture periodically shifts. If you have missed it clinically pre-op, you may have a surprise on the other day that the child would earlier be having a right-sided face turn, and after this surgery, suddenly she starts having a left-sided face turn. So if you have done a augmented Anderson's procedure, you don't lose much. You can easily do the other two yoke muscles, and it would convert as a bilateral augmented Anderson's, which is the described procedure for the PAN or periodic alternating null. Now, this is what we did, like in this child. The surprise on the other day, and after the other yoke muscles, the head posture is corrected. So this becomes a 4 horizontal recti supramaximal recessions or a bilateral augmented Anderson's. How do we deal with children who have an eccentric null with strabismus? That means they have two problems together, and there is a nystagmus and there is a squint. Now here you have to remember nystagmus surgery is always to be done on the dominant eye. If you do the surgery on the non-dominant eye, it will not correct the nystagmus. So you have to correct the nystagmus by operating on the dominant eye. If the eccentric null is in adduction, let's say like the upper picture, and there is an ESO deviation, if you just do one muscle surgery, an MR recession of the dominant eye, here it will have two birds shot with the same stone. So there will be a esotropia corrected as well as a nystagmus also would have shifted the null to the center, and it would be fine. But if suppose there was a exodeviation associated with an adduction null, this complicates the picture. If you do an MR recession to correct the nystagmus, you would worsen the exotropia. So what you will do is dominant eye surgery to correct the nystagmus, and the squint which is there prior to the surgery as well as the one which you have induced yourself would have to be managed by you by an R&R or surgery on the other eye. Vertical AHP, that means they have a chin down, like this child in the picture, he's having a chin down position, can also be corrected by the same principle, but here you have to work on the vertical recti. So for example, in this case, a bilateral superrectus recession of 6 millimeter has been done, and he gets corrected to straight head. Sometimes you may have a mixed head, abnormal head posture. That means there is this girl, as you can see here, she is having a tertiary position null, and there is a right-sided left face turn and a right dextro gaze null as well as an elevation, dextro elevation gaze null. So what do? You operate on both the lateral rectus and the superior rectus on the right eye and the medial rectus and superior rectus in the left eye. And this corrects the situation. On the same principle, torticollis or a head tilt, which is also seen in some children, can be operated. And our choice is to operate on the oblique muscles, but even the horizontal recti have been shifted up by some people, and the vertical recti have been shifted horizontally to get a similar correction. So this is this child pre and post, and this is being corrected. Now, coming to the four muscle recessions, we said supramaximal recessions can be done. One is in the periodic alternating null, but they have also been mentioned for people who have no eccentric null to dampen the nystagmus. In the hope that by doing the four horizontal supramaximal recessions, you will weaken the forces of the muscles and reduce the nystagmus. But this advantage is short-lived, as we had seen in the studies done in RP Center, that after 3 months, the nystagmus comes back to hit us again. A Hurtle-Delosso procedure, as I mentioned, disinsertion and reinsertion of the four horizontal recti has a similar effect. That means the advantage is only for a few months, although it has been claimed by Hurtle-Delosso group that because of the proprioceptive apparatus being shifted, the nystagmus gets dampened. But we have seen that the effect doesn't last longer than 3 months. Artificial divergence we can induce in cases who have a convergence dampening mechanism, but you have to be very careful that you do not induce an artificial divergence or exotropia, which is uncontrollable. Sinski's procedure is an interesting procedure. Sinski, as you all cataract surgeons might be remembering the name of Sinski, and he got fond of nystagmus in his later part, and he advocated an anterior extirpation procedure, a total extirpation of all the four horizontal recti. Na rahega baans na bajegi bansuri is the principle, but it is not a procedure to be recommended at all. It creates lot of problems, and then whatever is the leftover muscle cannot be handled. So we would not recommend this surgery at all. So finally, to conclude my talk, I would say we have the take home points. What do we do? One is optimal optical correction with glasses. For albinism, we may have to use photochromatic glasses to make the child's life better. Contact lenses may be helpful for high refractive errors. Imaging should always be done in cases of spasmus nutans, any vertical nystagmus, any seesaw nystagmus, any acquired nystagmus, any child complaining of oscillopsia, any child having an asymmetric nystagmus should be always imaging be done. So when you do surgery, what do? A definite eccentric null to one side, you can do a augmented Anderson's procedure. What is that? MR 9 millimeters, LR 12 millimeters, yoke muscle recessions. But if you have a head posture of more than 40 degrees, you will have to add resections on the opposite muscles of MR6 and LR9, which will correct the extra large AHPs. Cases with periodic alternating null, you do a bilateral augmented Anderson's, that means 912, 912, MR-LR. Cases with fusional maldevelopment nystagmus with squint, correct the squint and mostly be happy that the nystagmus becomes less. So a Sciantia syndrome or a nystagmus blockage syndrome, you do an MR recession with a posterior fixation. That means the we put a Farden suture on the medial recti. Cases with no definite null, we have tried auditory biofeedback, we have tried acupuncture, supramaximal recessions of four horizontal recti, and even the Hurtle-Delosso procedure. They have all been tried, but with limited success. So I think I would like to thank you all for listening to this talk. And if you have any questions, we can go ahead. Thank you all.
Thank you so much, sir. And Pranita, just carry forward the discussion. Check if there are any questions by the students.
Yes, sir. Thank you so much, sir, for that excellent talk that you have given and so very well explaining every point in such depth and clearing everything point by point. I think we have Dr. Abhipsa and Dr. Anita. So, Anita, ma'am, would you like to ask any questions from sir, or are there any questions from the students that you would like to carry forward the discussion on?
Very good evening, sir. Good evening, Pranita. It's always an honor to hear, sir, and such an informative lecture. Nystagmus is never easy, but after listening to sir, it is always very looks very easy.
It is.
Yeah, so
You carry on.
everything we have learned from you only. So nystagmus, definitely you have made it very easy. So one question from residents: what is the exact indication of surgical intervention? How much head posture? Like at what head amount of head posture we should go for the surgery?
Right. I think it's a good question that if you have any abnormal head posture that is more than 15 degrees is what we do. So 10 degrees sometimes if it's there we may not bother because it is acceptable and the child may not be having much of distress. But any head posture abnormal, eccentric, which is more than 15 degrees, we would like to do a surgery.
And sir, in unilateral nystagmus, if there is some torsional or vertical unilateral nystagmus, what are the points? What are the important points to take care of? And while suggesting imaging in such patients, what we need to ask?
Yeah. So any unilateral nystagmus or asymmetric nystagmus, because many times it may not be unilateral, it may be asymmetric, and or you have a disconjugate nystagmus. Now the difference between dissociated and disconjugate should be understood. Dissociated means that the two sides are having different amplitudes, and disconjugate would mean that they are having opposite directions even. So if you have any such thing, then you should always do an imaging. Imaging is either, if possible, MRI. But if suppose there is a small child, not MRI is not compatible, you can do a CT scan also to rule out any glioma, chiasmal glioma, which may be there in these children. Fortunately, only about 10% of these children may have a malignancy. But if they have, you have to attend them. But majority of them, you'll find they will be having a benign spasmus nutans. As I mentioned, there will be a triad of benign spasmus nutans. They have a torticollis, a head tilt, they have head nodding, and they have a nystagmus, which is asymmetric. So if you have this triad, you think about spasmus nutans. And once you have cleared imaging, then you can just wait and watch, explain to the parent that this will usually resolve by about 18 months or 2 years.
Yes, sir. Thank you. And what is the earliest age? I think you have already mentioned that at around four
Four
age.
years, around 3 to 4 years before he goes to school. Now we recommend that you can do. Yeah.
Yes, sir. And what are the important points to counsel the parents before, like when the waiting period is there? So, what are the important points that we can tell the parents that these are the things?
Yeah, so one is that the refractive error may be associated, it should be corrected. So make him wear the glasses. Many a times, even though there is some sensory nystagmus, that means they have some problem associated with retina or optic nerve, even these children may be benefited by refractive correction. So one should not miss that and give them the best possible vision that is possible. And if you have any associated condition which needs to be corrected, for example, there may be a cataract or a corneal pathology, then these may be corrected in time. And so that we can recover the nystagmus. So I think a study done in RPC by Professor Khokhar had shown that children who have a bilateral cataract have a much higher incidence of having associated strabismus and nystagmus. So these children, if you are treating in time before, let's say 6 weeks, 8 weeks, then the cataract is done, then usually the nystagmus can be reduced or restored. So this is something which you have to keep in mind that we take care of. And those children who are having no associated ocular problems as such, we need to wait and watch, have a stable face turn. So always ask, is it changing? And this will only happen when the child is asked to do some visual task. If you just shine your torchlight, you may not even pick up a head posture. But the moment you ask him to read a chart of interest or maybe some pictures or a video, then suddenly you'll find that his head has turned. And the finer he has to see, the full head posture would be adopted. So to get the full picture, you may have to make him see something which is of his interest. So do that and then tell the parent that is it changing? So don't jump on that because you might easily miss a periodic alternating null nystagmus, which is going to be another surgery required on the for the surprise that you will have the other day.
Yes, sir. So, one last question. Like when we are going for the surgical intervention, what should be the counseling? Like parents ask how much it would be corrected, the head posture, or the amount of nystagmus. So, what should be the ideal statement while counseling the patient's parent?
Yeah. So,
Yes.
Anita, I think that's a very good question because many a times parents may expect that the nystagmus will be eliminated or corrected.
Yes.
Mm.
So we have to counsel them that we are not actually reducing the nystagmus. We are only taking advantage of a null position so that their vision becomes better. The nystagmus is neurological. We are not doing anything for that. We are only taking the head posture corrected. So this is one counseling which is required, that they may still be having an nystagmus later on. And second is how much is the head posture corrected by surgery depends on what you do. So if it's a 30 degrees and you do an augmented renaissance, it will be fine. If it was, let's say, more than 40 degrees, you just did augmented renaissance, you will have a residual head
Rest.
posture.
Yes.
And if you have done already a four muscle surgery to start with, you may be okay with that. Sometimes there can be a recurrence of small head postures after a few years, which has come in follow up, let's say 5 or 10 years later. We have come across some cases. In those cases, you can again do a surgery to re-establish the null shifting.
Thank you so much for explaining, sir, so nicely. Pranita, do we have any other
Yeah,
questions?
I think Abhipsa will be
Yeah.
raising few questions.
Yes, Avipsa, nice to see you back here.
Nice
Yeah.
to see you too, sir. Sir, I think everything has been discussed. I just have one question. What about patching for the children with nystagmus? So some patients do have less visual acuity in one eye, and their, refractive error. With the refractive error, also they are not corrected.
Yeah.
So what can be done?
So one is that if they have an isometropia along with, they would have an amblyopia. So if you have to treat amblyopia first, you would have to do a patching. And if they suppose have a manifest latent nystagmus, the nystagmus will worsen. So if you cover the good eye, patch the good eye, then nystagmus will become worse and the vision will drop. So you need to counsel the parents that we have to do a patching in order to correct the amblyopia. Initially, the vision may drop, but don't worry. You need to pursue it, and gradually, as the amblyopia resolves, the vision becomes better, and the latent nystagmus also, the manifest component becomes latent, and then it will be fine. So occlusion has to be done. At one time, there was a suggestion that you do an inverse occlusion in these children. That means you cover the amblyopic eye. Uh, but that is not really the recommendation. So what we would suggest is that do the conventional occlusion, the patch the good eye, have the nystagmus worsen, which is going to happen, but gradually as the vision improves, it will be all right. It will be corrected. You
So
may
our
also use penalization, by the way. That's another option. If you don't want to patch, then penalization can be done. If suppose the parents are too, concerned by this fact that they don't agree for that, or the child doesn't cooperate, then penalization. What do we mean by that? That means you can use either an optical or a pharmacological penalization by using a high plus or a atropine penalization in the good eye. We are blurring the vision of the good eye so that the amblyopic eye becomes better.
Sir, what about binocular therapies like binocs that we can also do for these children?
Amblyopia therapy? Yes, you
Yeah.
can use Minox like in any amblyopia, but generally what we see is that amblyopia therapy, the best treatment is still patching. Uh, Binocular vision therapy does work or only works when there is mild amblyopia, mild anisometropic amblyopias. So first you have to come to that level. So occlusion is the first step. And then if you improve that vision and he comes to that level that is about, let's say, 618, 612 vision, then you can do binocular vision therapy by whatever name.
Okay. Thank you, sir.
Okay.
Thank you so much, sir, for that wonderful lecture. And I think everyone has all the questions have been well covered and discussed. Sir, I think it was an honor for us to have you here in this in our DOS-PEP series. And this is a token of appreciation for the class. Praful, sir, would you like to say a few words before we close it?
Thank you so much, sir. And if you join us for our annual DOS at Bharat Mandapam, we'll give you a frame certificate of this.
Thank you so much for that honor. And I would always have the love and affection of people. That is much more than these certificates. But yes, I am always enamored by your love and affection. And thank you for that, all of you.
Thank you so much, sir.
Thank
And
you, sir.
Pranita, I
Thank
think
you. With that,
yes, we
yes,
can conclude. Students
yes.
are
So
very
with that,
happy. I'm getting a lot of messages. Nice lecture, informative lecture. But
yes,
I think we kept it as the last session of our Strabismus module, and it's
yes.
really the huge hit for us.
Okay. Thank you once again,
Pranita,
Praful,
please
for organizing
conclude.
this. Thank you, Pranita. Thank you,
Rocky.
Anita. Thank you, Vipsa. It was really a
Thank
pleasure to
you.
join with you all. And we'll continue to have more such things as you keep on doing. Thank you.
Thank
Thank
you,
you,
sir.
sir.
And
Thank
thank you
you.
all the audience who
Thank
Yes,
you.
are
we'll keep on